Good afternoon, or depending on where you're joining us from, good morning. Welcome to a very special open classroom presentation offered in partnership with the American Academy of Social Work and Social Welfare. I'm Janet Gillow. I'm the Director of Professional Development for the Brown School here at Washington University in St. Louis, and I'm so happy that you're here for today's program. Just by way of a little bit of housekeeping, for those of you joining on the Zoom webinar, you probably know this, but in the webinar format, we can't see or hear you, and we can't call on raised hands. Chat features enabled, and we do definitely want the audience involved today. So questions and comments are welcome. Put them in the chat. You can send things that only the host and panelists can see, or you're welcome to share thoughts with the full room. We want to extend a special welcome to folks joining us on YouTube, either now live or maybe viewing this recording in the future. I want to make you aware that we're not able to moderate Q&A through YouTube though. So before I pass the microphone over, I just want to let you know what we have coming up next week at Open Classroom. Open Classroom are a series of free, open to absolutely everybody, 1-hour webinars sponsored by the Brown School, often in partnership with other wonderful organizations. Next week, we have 3 programs. So December 7th, that's Tuesday, we'll be hearing from Dr. Lombe Mwamba. She's in Zambia and delivering a presentation with us on sport for development, empowering individuals and communities in Africa. We're going to be back on Wednesday, December 8th, with a program on understanding and improving St. Louis's not-for-profit sector. We're going to be joined by colleagues from the Community Innovation and Action Center at the University of Missouri, St. Louis for that one. And then finally next week on December 9th, a talk entitled, "What do people mean when they say AI, ML, big data, or data science?" Dr. Liberty Vittert of Olin Business School here at WashU is going to be delivering a talk that's part of our Artificial Intelligence in the Social Sciences series. So a diversity of topics and literally dozens of things are available to sign up for. I'm going to throw a link in the chat in a moment. We would love to have you come back to us. But now for today's program, and to welcome our distinguished panelists, it's my honor to be passing the microphone over to Mary McKay. She's the Nibor Family and Centene Corporation Dean of the Brown School and the President of the American Academy of Social Work and Social Welfare. Please take us away, Mary.
Thank you. Thank you, Janet. Thank you for everything that you do to make the amazing speakers that we've had, the content that is available on Open Classroom, making that accessible to so many across our networks and across our communities. So good afternoon, everyone, or good morning or good evening, depending on which time zone. I have the privilege of introducing our speakers and really introducing also you to the Academy. So Ron Manderscheid, you are a board member of the Academy, which consists of amazing scientists within the fields of social work and social welfare that really are working across fields on some of our intractable kind of social challenges. And you as a board member are one of the leaders of the Academy, really supporting those fellows and really elevating a set of issues and how science and how our work can really make a difference in the world. I have a bio here that stretches pages on my iPhone, so I'm not going to read all of those pages of distinguished career, but I will tell our audience that your career spans work within Congress, the federal agencies, across NGOs, university teaching. You have a number of adjunct appointments, Bloomberg School of Public Health, at USC, the School of Social Work, and you're also the president CEO of the National Association of County Behavioral Health and Developmental Disability Directors, and the National Association for Rural Mental Health. All those words mean that you are a leader, constantly, an advocate for social justice, advancing equity, and certainly a champion around mental health issues. So Ron, thank you for your leadership on our board at the Academy and for your leadership in the field. So Stephanie Campbell, I've been trying to figure out our connection to New York, and I'm still going to work on that after this presentation. But your background includes journalism, lobbying, time working with the New York State Assembly, the New York State Senate, and a few years working as a high school social studies teacher. How about that for some historical digging? as well as you hold an MSW, a degree in social work. You've been working in the recovery movement for the last 6 years. For the last 3 as the director of the independent office of the New York State Behavioral Health Ombudsman program. Your office oversees the implementation of a statewide initiative designed to ensure that New Yorkers can access insurance coverage for substance use and mental health services. You're also an adjunct professor at a university that I care about a lot because I also taught myself at New York University. So Stephanie, welcome. Ron, thank you for organizing and bringing Stephanie to us. And I'll have you go ahead and lead off our program.
Yeah.
Thank you.
Thank you very much, Dean McKay, and congratulations again to you on your new, very recent appointment as the Vice Provost at Washington University. We're all very proud of you, so thank you very much. Also glad to be working again with my colleague, Stephanie Campbell from New York. She and I work together frequently on these types of issues. So I know that a number of you who are here with us today are here because you have a family member, a friend, a colleague, a neighbor, maybe even you yourself, who have suffered from problems of drug use, maybe even problems of drug overdose, and maybe even someone in your family or your friendship group has died as a result of drug use. I think the main lesson we want to bring to you and what we're going to say today is that treatment does work. One can recover from this, and when you recover, you need the support of other people to do that. So being a family member, being a friend, being supportive of someone who's going through this trauma is just very important. And we thank you for joining us today. And we'll want to hear from you a little bit about your experiences as well. So we're going to talk for about half an hour, but when we're done doing that, we want to engage you. And some of the questions we'd like you to think about as we are talking here, what are you actually seeing out there in the field today? This problem continues to evolve and change. So us talking about this today is very different than if we were talking about this a year ago or 2 years ago. So what are you seeing? What works and what doesn't work for you or for your family member or your friend? Do you have any important anecdotes for us on the process of recovery? Recovery is a very personal experience to most people. And I think most people learn recovery by trial and error. Do you have anything you would want to tell us about that? And finally, how are you taking care of yourself during the pandemic? So I want you to think about those things, as we go forward here. So what we're going to do first is outline the problem a little bit, talk about solutions, and then Stephanie and I are going to interact, but we're going to stop doing that at about the half-hour point so we can engage you in the process here. So to begin with a few statistics, and these will be the only ones we'll present in the whole presentation, drug abuse is a very, very pervasive public health emergency in the United States. Let me cite some numbers. About 10.5 million Americans abuse opioids every year. 10.5 million, that's 3.8% of the adult population. 37.3 million are people who've used some form of an illicit drug in the last year. 37.3%, that's 13.5% of our adult population. Then 53 million are people who've used illegal drugs or misused prescription drugs. That's almost 20% of our population. So you see that we have a very, very pervasive problem, yet only about 1.5 million people actually get formal care. So compare that 1.5 million against the 10.5 million. We're only reaching about 10% of the population that needs care. Another statistic, and then I'll stop with the statistics here. The number of people who've died from an overdose has grown just dramatically in the COVID period. So if you go to the pre-COVID period in 2019, there were about 50,000 deaths in a year. If you come up to 2021, we are now in excess of 100,000 deaths. We've doubled in just that 2-year period. And as we've doubled, things have changed as well. The configuration of who is dying has changed, and we'll talk a little bit about that and so on. So just wanted to point out that we have a very, very pervasive problem. It has very serious consequences. You can die from this, but also treatment works and you can recover. So I want to give Stephanie an opportunity to speak to that while I go and put up our slides here. So Stephanie, you have comments on that?
Sorry. Yeah. Hello, everyone, and what a gift to be here work with Ron to present some of the information and have this conversation with you today. So first, I like to sort of introduce myself not as a public policy person, which I am, or a professor, which I am. Those things do not define me. What does define me is that, I'm a person in sustained recovery. And what that means for me is that somewhere in 1989, someone reached out to me when I was a homeless street kid and gave me the message of hope. And that hope allowed me to begin my pathway to recovery, which includes harm reduction and other means to really live a life worth living. To what Ron said, we are now facing since the numbers of overdose deaths have been collected. We now have more overdose deaths than in a 12-month period than we've ever seen. And, I'll talk a little bit about that in some of what's happening here in New York State and across the country. But with more than 100,000 opioid related overdose deaths. And I believe, and others believe, that that's underreported, substantially underreported. This has now surpassed COVID-19 deaths, right? And when we also factor in increased suicide completions, and we've seen a real disparity, for folks needing, substance use and mental health treatment during the pandemic. So we're gonna talk about that, and we're gonna look at the way in which the cross contamination of fentanyl, across the entire drug supply, has really had a significant impact on naive and recreational drug users who are now losing their lives to overdose. So, but we're going to also talk about hope and the healing that happens when folks get what they need. So I'm going to turn back over to Ron.
Okay, thank you, Stephanie. Excuse me. So I put up the first overhead here to give you a little bit of perspective. COVID-19 has changed the game regarding drug use. Can't overemphasize the importance of that, and which we're trying to show here. And we actually titled this event, The Twindemic and Its Consequences here. So we have the twindemic of COVID-19 and opioid use. And the two do relate. So COVID-19, the disease itself, can lead to neurological changes in people, which lead to mental illness, which lead to opioid use. So those linkages have been established. We know, for example, that a person who develops depression or anxiety is at 3 times the rate likely to develop opioid use. A person who does opioid use is 2.5 times as likely to develop depression or anxiety. So these things interact with each other. And there's an obvious linkage here directly with COVID through neurological changes that occur, particularly in people who have long COVID. And what's been found in the research that's been done thus far is that about 30% of people who have COVID develop long COVID, and then a subset of those who develop long COVID develop neurological changes that lead to mental illness and substance use, basically. So that's one route. Another route here is the mitigation factors due to COVID. The mitigation factors that were employed in 2020 included things such as, children going to school remotely, people working remotely, family members being isolated from other family members, a lot of social isolation and lack of social engagement. That social isolation takes a toll on people. Being at home with the same family members and your children, 24 hours a day, where you and your spouse are working and your children are going to school in another room, takes a toll on people. And it did. So in effect, the rates of behavioral health disorders doubled in the COVID period. The traditional level of behavioral health problems in the US population is about 20%. We went beyond 40% as we got into the depths of 2020 and beginning to get into 2021. So there's the direct mechanism of COVID-19 through neurological changes. There's the indirect mechanism through what the mitigation factors did to people's social lives, increasing social isolation, increasing stress for people, and so on. So it's very obvious why COVID-19 would relate to opioid use. I've explained a little bit about the linkage with depression and anxiety, but also chronic illness ensues from this. And maybe Stephanie would want to comment on chronic illness here.
So the chronic illness piece, what we've seen during COVID is because of the sort of perfect storm that Ron outlined a little bit, the impact on individuals with substance use and mental health conditions is that because of the portals of entry into the brick and mortar treatment clinics and hospitals, those have shut down somewhat in certain parts of the country. And certainly we've seen a reduction of, because of social distancing requirements, because of the CDC guidelines, which, have restricted certain, closure protocols to happen. Folks have not, necessarily been able to get access to certain treatment options. We see this across the board in terms of, other comorbidities, physical med surg issues. And that has sort of, helped, really spur folks getting sicker. And so sometimes by the time individuals get to, treatment, they have significant comorbid issues which prevent them from being able, to engage in traditional, some traditional forms of treatment. So those are some of the challenges that we're looking at and trying to address, certainly here in New York State and nationally.
Okay, thank you. Let's move ahead. Let me go to the second overhead. So in this overhead, what we want to talk about are some of the interventions that can be done at various levels here, all the way from the transformations at the community level down through treatment onto rehabilitation, recovery, and support. And so let me lead off a little bit here on the left side of the diagram. Got several things here. So obviously, I guess in public health, we would always believe and preach that prevention is better than treatment, always. So if we're going to think about prevention on substance use, we need to examine the social and physical determinants of health, the SPDOH, and how the SPDOH lead to trauma in people and then lead to behavioral health conditions, including opioid use. Over time, we are gradually beginning to do more work on this with the underlying idea, if we could change a social determinant of health to make it less likely that a person would develop a crisis, we can probably impact upon the number of people who actually develop behavioral health conditions. What do I mean by the social and physical determinants of health? I mean things such as the question, does a person have necessary social support? COVID took away a lot of social supports that people have. Does the person have a decent place to live? Or do they live in a rat-infested building or out under a bridge? Do they have a means of income, or are they living hand to mouth every day? We can go on and on and on with these social and physical determinants of health. Do they have a family that they can rely on? All these questions, we need to begin pulling these social and physical determinants of health apart, excuse me, and to actually then, begin working on them and examine which of these play particular roles in opioid use and drug use, and then beginning to do the work to modify them. Vulnerability. Do we have, and I think as we learn more about genomics and so on, we will find out that we have people who are particularly susceptible to, drug use, that just a little bit of use of drugs will have a major impact on them over time. And those people are more vulnerable if they need to have, a piece of surgery done and they're given an opioid. The opioid may be enough to trigger a long episode of opioid use for that person. So we need to also look at how we can make people more resilient to opioid use. And important work needs to be done in that area. Community. What is the role of community in all of this? There's very interesting work ongoing right now in the question of how we can empower communities to address their own concerns. I'm doing some work on rural communities in the United States, Canada, Australia, and New Zealand. And there are some basic principles in that community work I will mention here just briefly. Principle number one, listen to the community. Listen to the community, because the community knows better than you, the researcher, or you, the policy person, what's actually going on there. Secondly, include historically excluded groups, and they will vary from community to community. In Canada, those are indigenous populations. In Australia, they're indigenous populations. In the US, they may be Blacks, they may be Hispanics, or others. You have to bring those groups into the process in a functional way. And third, you need to let emergent leadership come out of that community through bringing people together in various types of social events. And if you do those things, what will begin happening is that your community will begin self-organizing to address some of these problems, such as opioid use in the community. For example, I'm reminded of a place called Mass and Cass in in Boston. It's an intersection in downtown Boston where a lot of opioid use occurs every single day. So the question becomes, how could work be done to organize that community to work with the people who are at that intersection, who are using opioids, to change the situation? And finally, parity of insurance. We are still climbing up the hill, trying to get parity for behavioral health insurance in the United States. We can thank Patrick Kennedy and his father, Senator Ted Kennedy, for the original parity legislation in 2008. It's been now well over 10 years since that's been passed, but we are not fully implemented. We need to continue working on that. If you do not have insurance coverage, you're going to have great difficulty getting care, basically. Great difficulty getting care. So those are some of the community factors that we think need to be worked on in order to make changes here. Let me turn it over to Stephanie to have her talk a little bit about some of the treatment factors here.
So, and I'm assuming, Ron, that are we looking at the questions, or are we working directly off of this chart?
We're working directly off of this, and we'll come to the questions.
Oh, great. So in thinking about, what we see in treatment, we've timely access to treatment is still a major contributor to preventable overdose fatalities. Here in New York State, the office that I oversee, which is the first in the nation Office of the Independent Substance Use Disorder and Mental Health Ombudsman program, which is also known as CHAMP, works to assist individuals with a substance use or mental health condition to use their health insurance coverage and to identify, refer, and resolve complaints that are made by or on behalf of consumers regarding their coverage. The issue that we're seeing in terms of access involves what Ron just spoke about, which is parity, and I'll talk a little bit more about that. But being able to get into the front door, right? And with COVID, what we've seen, unfortunately, one of the unintended consequences of some of the focus on COVID is that the unintended consequence is that it's really prevented folks with substance use and mental health to be able to access treatment, and that includes even getting into the hospital, showing up at the ED from an overdose. If you are not able to get in the front door, then you will further decompensate. And this is, of course, unfortunately led to a lot of the surge. So that's something that we're working on both on a state and national level to try to, help resolve some of these issues, to really be able to get folks access to care, and also for that care to be integrated. Sometimes folks yo-yo between, if it's a primary diagnosed substance use disorder, but they have co-occurring mental health conditions, they may not be able to get substance use treatment until they're stabilized on their mental health meds. However, if on the mental health side, sometimes what we see happening is that folks won't be able to get into the door of a mental health care facility unless they've been abstinent for X amount of days. So it further prevents individuals from truly having integrated care, and that's something that has been challenging, and we're working here in New York State to address some of those issues through creating licensure for truly integrated mental health and substance use care. The other issue that we're seeing is, while the bottlenecking has occurred for folks being able to get into the front door because of repurposed beds for COVID, we've been able to really connect folks in community with peers, individuals with lived experience, and I'll talk a little bit about that later during our discussion. But having folks, maintain a connection, right? And I love what you said, Ron, about in these rural areas, or where really having person-centered, community-centered advocacy, and we've seen areas of the state where that's done incredibly effectively, where you have people from the community who are in recovery, who are empowering others and addressing issues as they come. So, for example, in the western part of the state, we had a number of an encampment, a homeless encampment, in which folks from the recovery community were, going into that encampment, helping support individuals. And when the local authorities were, wanting to, to move folks out of that, encampment where they were receiving services while they were waiting to, perhaps get into treatment or not get treatment or get other services and supports, that the advocacy of folks, with lived experience in those, working with those vulnerable folks, really is creating a positive conversation to try to help support individuals.
Excellent, excellent. So let me just say a few words about the right side of our diagram here: offering support, community integration, rehabilitation, and recovery. So I would say in the substance use field, the recovery concept is a little bit older than it is in the mental health field, but the underlying idea is very similar. Recovery involves a long journey for a person to regain their own voice, which can be very difficult sometimes. It involves regaining your social support network. You're having friends who support you, family members who support you. It involves regaining your roles in the community, having a job role, for example, in the community, or having a volunteer role in the community. So recovery is a very important process, and we've learned, over, I would say, the last 20 to 25 years, how to configure our health services and behavioral health services to better promote recovery of people with behavioral health conditions. And so then the basic principle here again is that recovery does occur and people can recover from these illnesses, including opioid use, through careful care and through going through this process of, in effect, re-engaging with yourself and re-engaging with the community. And I think I can't overemphasize the importance of that. So those are a little bit of look at the front end of the system on prevention, on the treatment level of the system, and on the rehab and recovery end of the system. So I'm going to stop sharing the screen. And we're going to move now to a little bit of interaction between Stephanie and I on some of the issues that we were talking about here, and we've prepared some questions for each other. So the first question for Stephanie: how can state and local government work with public health advocates to stay on top of this crisis?
Well, that's a great question. And I know that here in New York, as the overdose deaths had continued to climb, public health advocates, recovery advocates, family members, families of loss, worked with government officials, and in recognizing the direct effect that stigma has on exacerbating discrimination that's experienced by individuals with SUDs, including their families. And in particular, the difficulty that they faced when they were attempting to access treatment and recovery support services. Advocates really understood the need to humanize the face of addiction, which is why when I speak publicly, I first start off by identifying myself as a person in recovery. For a long time, we've hidden in the shadows. We were afraid because of the war on drugs and the negative public perceptions that we didn't want to, identify and use our lived experience, which is proven, by the way, extremely valuable. And that's not just anecdotal. That's that's real. And so, advocates understood the need to humanize the face of addiction and created a targeted, multi-pronged platform to mobilize communities across the U.S. to change public policy. Specific to, similar to what happened during the AIDS and other, human rights and civil rights, social movements, right? There was a recognition that we first have to see these people as human, right? And deserving of care. In the social work world, we often talk about, in terms of policy, the undeserving and the deserving, right? So we developed a strategy that really centered around the need to combat addiction by ending the stigma and discrimination of this, normalizing this as a medical condition, not a moral deficiency, and that we really want to talk about that, and demonstrate that the power and promise of recovery. We do recover. We're not, just people who are sensationalized by the media, but there's a real pathway and multiple pathways actually to recovery.
Yeah, excellent. So let me go on and say just a couple of things here that are related issues that I want to bring to the table because I think they also play a role. And the one I'm going to pick up on here right now is, so I'll ask myself the question, does racism, sexism play a role? So when you get into racism, sexism, you're in effect talking about a social determinant of health and how that social determinant of health impacts upon a person and their interactions with others. And we do know, for example, that people who are exposed to racism can die up to 7 years younger than other people simply because of what they have been exposed to. So what has happened to that person is that person has been exposed to a trauma in those interactions due to the social determinants of health around racism that then impact upon that person developing behavioral health and health conditions, including opioid use, which can result in death for that person. Or it may not ultimately involve opioid use, but it may simply involve premature death. And so premature death is a very important indicator of how well we're actually working on these issues. And we need to actually do much more work on that. People who suffer from behavioral health conditions in general, in the community, I would say in general, and we published this research, probably die 6 to 8 years earlier than other people, due primarily to their behavioral health conditions. People who are cared for in the public mental health system can die as much as 25 years earlier than other people. So there's some very important work here. And the underlying mechanism, again, is like the mechanism in racism. It's racism leads to trauma, leads to a condition, then leads the condition to get worse and the person dies prematurely. So a very important thing. Let me go back to Stephanie here. Another important topic, what is the role of self-direction in care and recovery?
Well, it's connected to, that dignity, right? The idea that individuals, have decision-making authority over the services, and that they can take direct responsibility in managing and participating in the decision-making of their care. It's an alternative to traditionally delivered and managed services, such as the agency delivered model. And self-directed care also allows, individuals that dignity and responsibility in the planning process, that, they're able to, develop a person-centered plan, which is directed and really builds upon, resiliency, strengths, capacity, and desired measured outcomes. It's not, traditionally it's been sort of the provider that said, well, this is what, you should do. And even in terms of abstinence-based, the focus on abstinence-based, right? There are some folks that for them, abstinence is not their, goal. That recovery for them means, a pathway to health and wellness that does not include, the traditional abstinence only. So, and we rewrote some of, those regs here in New York State to really address that. But also that there's a participatory process in that recovery, in their recovery journey.
Yeah. So you raised an interesting issue in your response here that I want to pursue for a second. So one of the things that's in the social media literally today, and I saw it on CNN early this morning, is the whole issue of the use of fentanyl strips for people who use fentanyl so they know that they are not going to overdose and die from the overdose. So fentanyl strips, in effect, are a tool to prevent overdose. How would you react to that as a state policy person in the context that you just described?
Bravo, long needed, much appropriate. Listen, we have to start talking about substance use in similar ways that we talk about other chronic conditions. During the AIDS epidemic, I started my advocacy with ACT UP, right? And what we were trying to say to public health and, and government folks who moralized, AIDS as God's response to, being upset with homosexuality. We said, let's give people condoms. Let's, provide housing for, let's, keep people alive. The dead do not recover, right? And similarly, and I've seen these similar situations in hospital rooms that I visited with individuals who've been stuck, on gurneys and hallways with no dignity, with, for hours on end, with no medication to relieve them of their withdrawal symptoms. And then we wonder why they leave, go use, and unfortunately so often die. So yes, fentanyl testing strips, wonderful. Understand that there's a mechanism to test your drug supply. People are going to use drugs. Let's not moralize about that. People are going to use drugs. Let's allow them to test those drugs and stay safe and stay alive.
Yeah. Excellent. So another topic here we haven't talked about, let me comment a little bit and Stephanie can comment, the pros and cons of medication-assisted treatment. So medication-assisted treatment has been controversial in the field because some would say, well, it induces drug use. Others would say it's absolutely essential. I guess the view I personally would take is it is essential for many people in order for them to recover from drug use. And it should be used, and it's well developed. It's well supported by our federal agencies, by SAMHSA, by our state agencies. And now we also have mobile treatment teams to administer medication-assisted treatment. Remember, I told you about the people at the intersection of Mass and Cass in Boston. Mobile assessment teams to administer medication-assisted treatment would be very useful for the people at the intersection of Mass and Cass. So and I want to come back to Stephanie on this question as well, because I believe the original mobile treatment teams doing medication-assisted treatment were in New York, if I'm not mistaken. That true?
Actually, the first was in, I believe, Connecticut, but we were right there. I think we were running neck and neck with Connecticut, but yeah, in New York City. And that was one of the unintended benefits of COVID, was that it allowed for us to do things that we'd been advocating for years. I remember going to Portugal a few years back and seeing their mobile methadone, and I had conversations with my colleagues back here in New York State. We're like, why can't we do this here? And fortunately, we have now partners in the federal, in federal agencies that have been doing incredible work on this and have helped us, move opportunities to do this. But my point of view, again, would we tell people with another chronic condition that you shouldn't take medication to support your recovery? Right? We wouldn't do that. It goes back to stigma. It goes back to discrimination. And some of that, unfortunately, has been by, folks in the recovery community who didn't, use medication to support their their recovery journey. But there are essentially 3 FDA-approved drugs to treat opioid use, and those, those medications, buprenorphine, methadone, and naltrexone, have been proven to be life-saving and very effective in treating opioid use disorder. There's also alcohol use disorder medications and other medications. But truly, we need to get naloxone, which is used to prevent opioid overdose by reversing the toxic effects of overdose. We have to get that out to the community, and we've been able to successfully do that.
Yeah. Excellent. And I'm looking in the chat. There's actually a question. What are some of the best practices that are being implemented in New York that other states should adopt? We have a question in the chat that relates, I think, directly to what you're just saying here.
So are we speaking, when we talk about best practices, if we're talking about medication assisted treatment, the way that we have really effectively gotten medication out to the community is often through our mobile treatment teams. What those treatment teams do, in providing, and especially during COVID, in providing medication to stave off the physical symptoms and the withdrawal, Also assisting with counseling for individuals to address some of their mental health needs and others that are associated with addiction. And those mobile MAT programs that provide access to MAT for treating opioid use disorder for individuals that are unable to or unwilling for whatever reason to get to a traditional brick and mortar treatment facility. In addition, those mobile treatment teams help provide connections to services such as housing, such as food, other wellness services, and do a lot of community outreach as well. And the best practices is that individuals are screened for substance use disorders and opioid use. They're often provided telepsychiatry for medication, evaluation, and monitoring. In appropriate cases, they're induced for Suboxone and other MAT services. They're provided counseling and peer specialist support, and also referrals to SUD treatment and other local services. And again, if for those that are not ready to engage directly in medical treatment, there's the peer support services that are ongoing.
Yeah. So a related question here that we had, could you say a little bit more about the important role of peers in care and recovery? We haven't said much about that today.
Yeah, so here in New York State, we, again, we recognized that, as these recovery community coalitions expanded, so did the call for a more recovery-oriented system of care for folks with SUD and mental health. So we created, and called for and partnered with our government partners to create a certification here in New York State called, the Certified Peer Recovery Advocate. And those individuals, provide peer recovery support services. These are peer driven. They provide education and support services outside of the four walls. They've, a proven ability to fill critical care gaps that has led to increased state funding that employs these certified peers, in the full continuum of care. We know that, we were able to obtain Medicaid managed care approval for in-community services, and with a new continuing care component that included both peer support and family support navigators. So we were able to expand access to care through the staffing of peers in outpatient programs and emergency departments, as well as we were able to create the Centers for Innovative Treatment. Those are the CODI projects that expanded across the state, in addition to 24/7 open access centers. So these peers have been, hired to use their lived experience to engage individuals on the street and in hospitals, developing brief person-centered service plans, providing referrals and linkages to needed services. And they've been particularly effective with people who've been reluctant to participate in traditional clinical services. So also in understanding that the ways in which families are impacted by SUD. I mean, Ron talked about, increased anxiety and depression. Families are experiencing that. So there's family support navigators that are able to help them, heal as well.
Yeah, excellent. So let's go to a few more questions now, kind of transition from our interaction here to questions that we have in the queue here. And I want to again encourage you to put comments in here. Remember what I asked you at the beginning. What are you seeing out in the field? What has been working and not working for you? Do you have any important anecdotes to share? And how are you taking care of yourself in the pandemic? So please think about those, put some things in the chat. I'm sorry we can't show you and see you here. So, and follow up to the previous question, what's going on in New York? There's a second question, how does New York pay for it? Does it pay for it with SAMHSA funds or other funds?
So we get, there's a number of funding streams, but we've gotten some additional dollars, both through SAMHSA, the block grants through SAMHSA, and also through the opioid litigation settlement funds that are coming to us as well. So, and every year, the budget has, fortunately, we under the Biden-Harris administration, we've really gotten an infusion of money to help support that. But it also, we've gotten money due to the advocacy of folks on the, on the federal level that have really understood the value of providing, support to individuals that started way before the COVID period of time. That includes recovery support services.
Yeah, excellent, excellent. So, so here's another person. Here are some of the hot topics that I have been hearing about in the field. The first one, there's a shortage of counselors, therapists, and rehab centers are struggling to keep up with the demand. Absolutely true throughout behavioral health care, especially with the doubling of the problem level from 20% of the adult population to 40% of the adult population. That is why it's so absolutely important that we make more rapid progress in implementing integrated care so that we can work more closely with primary care physicians, physician assistants, nurse assistants in dealing with this crisis, and train additional people in MAT from the primary care practices, work virtually with them, and so on. On human resources are a fairly stable quantity in the sense that you don't just all of a sudden turn it around and double your human resources because there's a training period for people and so on. So we need to pay more attention to that as a field. The area, and I'm speaking politically now, the area of the field that gets the least attention in behavioral health is our human resources. We pay attention to everything else, but not to that. And as a consequence, we are having problems in that area of not training a sufficient number of people. The question becomes, how do we bring more people who are willing and passionate to work in this field? How do we get the resources to train them, et cetera, et cetera? Those are some of the policy issues that would ensue from that. Stephanie, do you want to comment on that also?
No, I do know that we've had incredible staffing shortages. The field has been literally crushed, in particular during COVID. The collateral trauma that people in the field are experiencing with, having lost their own, loved ones, family members, and then of course working in a field that, has also experienced incredible loss. So we really do need to shore up and support the workforce. I know that there's a real movement here in New York State to do that, and to really get, both, treatment and recovery professionals, the additional support that they need.
Yeah, excellent. And there's another comment in here that probably worth looking at. Concerns around the effectiveness of MAT on the new drugs.
Yeah, so again, I think what the effectiveness of MAT on the new drugs, are we asking, is the question whether or not MAT impacts?
Whether MAT is effective, for example, for a person who takes fentanyl versus more traditional opioid or methamphetamine or one of these other things, I think is the intent of the question.
I mean, that's an extensive answer. So I'm going to try to sum it up very briefly. We do have, as I mentioned, 3 FDA approved drugs. We also have a preferred formulary here in New York State for buprenorphine, which is one of the FDA approved drugs. Within that context, right? Depending on who you are, depending on your physiology, you're going to have the efficacy of those drugs is going to have a different impact on your recovery versus someone else's. So it really should be prescriber prevails, right? Like, let the experts who are professionally trained and know how to prescribe these medications work with their patients, full stop, and not have insurance companies deciding that or, anyone else. It really should be the experts who are doing that.
Yeah, excellent, excellent. And we put a plug in here for the new entity that the Biden administration is trying to create, ARPA-H, the Advanced Research Projects for Health, which would be a very practical center to develop innovative solutions to all health problems, including the use of opioids. So the very question we were just talking about, does current MAT work with the new drugs we're seeing out on the street? That is exactly the kind of question the ARPA-H Center should be taking up. So I think we want to be, as a field, supporting the creation of such a center and getting it funded at a reasonable level so that it can do work in that area. So there also is a concern in this same response that some of the funds that have been given to behavioral health have been used for COVID. I guess I quickly answer that. So I know a little bit about the numbers here. So as we went through the 20 months of the COVID period, the states were down about $500 billion, meaning there was less money because the states took in less sales tax revenue, had to spend more money on COVID, all these things, you put it all together, it was about 500 billion. The counties were down about 150 billion for all the same reasons. What the recent legislation did, including the American Recovery Act, is reimburse half of that. So about 300 billion was given to the states to compensate for the loss that the states had witnessed in that 20-month period. And about another 69 billion, I think, was given to the counties. I think, but I would say to the person who made that comment, you want to go to your local county and you want to go to your local state and ask how they are spending that money that came to them through the American Recovery Act, because that money is supposed to be spent not just on COVID per se, but all the related factors due to COVID. It's supposed to be spent on mental health. It's supposed to be spent on substance use. It's supposed to be spent on social isolation issues and so on. It's supposed to be spent on public health. So there is some money out there. What you got to do is you got to lobby to make sure the money gets spent in the areas where we want to see the money spent and that it doesn't get frittered away into other areas, I would say. So I want to then see if there are any other final questions before we begin to wrap up here. So if you have a final comment or final question, please put it into the chat box and we will respond to it. While we're doing that, let me also begin to wrap up again by going back to where we started and saying, we know that opioid issues are a very, very serious crisis in our society, but we also know that treatment works and people do recover. Stephanie's comments here on some of the important work going on in New York, document that most clearly, and people can recover. They can regain their life in the community. They don't need to die from an opioid overdose. And that's, I think, the most important lesson you can take away from this entire session. Let me let Stephanie make a comment here too and see if there's anything else before we wrap up. Go ahead, Stephanie.
Yeah, no, I agree with you wholeheartedly, Ron. I think that there's, proven evidence-based harm reduction, ways to keep people alive. We really need to, and I love what the Biden-Harris administration has really made a priority of addressing the overdose and addiction epidemic, and things like expanding access to evidence-based prevention treatment, and advancing racial equity issues in our approach to drug policy. Being able to really enhance those evidence-based harm reduction efforts, such as naloxone, sterile syringes, fentanyl testing strips, and testing for other co-occurring illnesses like HIV and Hep C. And we're working with our partners to try to reduce the supply of some of that fentanyl. But we really need to advance recovery in all sectors of society, including the workplace, and expanding, the addiction workforce, and expanding access to those recovery support services.
Yeah, excellent way to wrap up. So I want to thank everybody for joining us today. I'm going to share my screen again so we can see if I can bring it up here and go to the next. Put Stephanie's contact information and my contact information if you want to get a hold of either one of us to follow up on things. I'm speaking for myself, and I'm sure I also speak for Stephanie. We'll be very glad to talk with you. If we don't know the answer, we will go and find the answer and get the answer for you. So again, thank you so much for joining us. Keep working on the issue. People do recover from opioid use. So thanks very much.